Bir sonraki sunuma geçeceğiz. Rektum kanseri tedavisinde çok önemli bir başlık neoadjuvant tedavi ve neoadjuvant tedavinin radikal cerrahi etkileri, bunun geçmişini, şimdiki uygulamalarını ve geleceğini bize İngiltere'den değerli meslektaşımız Rob Glynne anlatacak.
Thank you very much. Well, I'd like to thank the organisers for inviting me, and Istanbul is an amazing city. So the last speaker has very clearly shown you the importance of the quality of surgery and highlighted margins, and also really highlighted to the downside of radical surgery in terms of the patient's quality of life. And I'm going to build a little bit on that in this talk. We have made a lot of progress since I started as a consultant in the UK in the 1990s, when probably every week one of the surgeons would bring down a patient into my clinic with a local recurrence. And I just can't remember when I last saw a local recurrence in that setting. Very few patients require an APR these days. We've got the role of transanal excisional microsurgery for very small tumors, still exploring that a bit. Chemoradiotherapy and local excision in some patients, particularly the sort of frail and elderly. The watch and wait, where we are able to avoid surgery completely. And the role of intensifying both the radiotherapy and the chemotherapy, and probably other modalities of treatment in there, to enhance complete clinical response as an option for patients, and to be able to select that for some patients in the future. In terms of radiotherapy, we have two breakthroughs really in the last 30 years. You probably don't use a huge amount of short course preoperative radiotherapy in this country, 5x5 gray, but it's a very flexible modality, and I tend to use that quite a lot in addition to long course chemoradiation. And what we showed with that is these are really quite modest doses. They're not doses that are designed to cure a cancer. They're designed to shrink the cancer and facilitate surgery without compromising your surgery, without compromising surgical morbidity. And we've shown very clearly that you can dramatically reduce local recurrence. But despite these modest doses, you are achieving complete pathological responses in maybe 15 or 20% of patients. And so there's a proof of principle there that once you can do it, you can probably do it more, and you can expand that. And I have been in the past quite a heavy critic of watch and wait, and I certainly have been persuaded more recently of the validity of all that data. And the thing to me that is absolutely extraordinary about the watch and wait is this is a presentation from GI ASCO, and shows that, yeah, some patients do have a regrowth. But what's extraordinary is that almost invariably that regrowth is endoluminal, and you can salvage that. And I will explore that a bit further on, because I think this is an immune phenomenon that we are seeing, that you're leaving the tumor in the patient and you're creating a vaccine in situ with that tumor, which you won't get if you remove the tumor. And again, yes, some patients do have metastatic disease, but most of the patients are prepared to accept these kind of risks if you are informing them completely. So we have a lot of modalities of treatment, mainly surgery and radiotherapy, a bit of chemotherapy. The molecular targets, targeted agents and immunotherapy are useful in the metastatic setting, but we have not shown these are of benefit in the adjuvant setting as yet. So historically, radical surgery, as has been shown, was really focusing on the speed at which how you could do it rather than the quality. And there were very limited uptake of lesser procedures, either in terms of surgery or in terms of modalities like the sort of papillon technique and external beam. So the total mesorectal excision was really quite a breakthrough, and going back to I don't know, I'm a radiation oncologist, so I'm kind of feeling out of my comfort zone talking about Halsted. But as a philosophical concept to a radiation oncologist, it's a kind of Halsted concept. But the interesting thing for me is focusing on the radicality of surgery didn't just improve the oncological outcomes, it improved the functional outcomes as well. And that's really important for us to remember, that it was doing two things. So you have this tension currently between radical surgery and knowing that all that radical surgery is of benefit, and then the watch and wait with no surgery at all. And how do we marry those two concepts up, which there are proponents for each of those on each side? Because there's a paradox here that in the UK, certainly, we are using less radiotherapy preoperatively, and many of us question the need for clinically T3 cancers, even if they are node positive, because with the quality of surgery, the local recurrence rate is so low. But at the same time as we're not giving so much radiotherapy, there are others who are saying, okay, let's give radiotherapy for clinically T1, T2, T3 cancers, and then we can avoid the surgery altogether. So there's a bit of a paradox, and also extending that up into the mid and upper rectum, which is slightly beyond where Angelita Habragama showed her data in the first place. So I've always been interested in some of the quantum physics, and Niels Bohr, who is one of the instrumentalists, and his Copenhagen doctrine looked at wave and particle theory and said they're not proper descriptions of the world about us. But he had this wonderful thing, isn't it wonderful, now we've got a paradox, now we can make progress. And I think there is that business that the debate and the polarization of things makes us discuss things in a much more meaningful way. So let's look at the nuts and bolts of some of these advances. So we know that it was recognized that it was actually the process of doing the operation, the APR, not so much the disease itself, but it was the process of that APR and the lack of the surgical margins there, which even Bill Heald showed that his APRs had very poor outcomes because he was coming in and coning and had an increased local recurrence rate. So how do we measure the radicality of surgery? I mean, are we going to look at quantity, or is it all quality? I mean, should we measure the length of the mesorectum, or should you put it in the bucket and weigh it? I think most of us would agree that this is a quality issue rather than a quantity issue. And we can judge the quality of surgery. For me, the big revolution in terms of my job has been seeing the surgical specimen and knowing that that surgeon has done, I mean, no one in the world is going to get a perfect specimen every time. And I've seen Bill Heald holding a specimen where there is a very obvious defect and smoothing it out to kind of make that defect look a little bit less. So even the best surgeon, if it's a big fibrous tumor with extension to the pelvic sidewall, even with radiotherapy, will not always get a perfect specimen. But it enables us to gauge things. And we can score the mesorectum, we can look at the examined nodes, although that's also a pathologist's issue. We can look, as has been talked about, high ties, the circumferential resection margin, the margin at the level of the levator, or even the distal margin. So can radiotherapy compensate for these if they're deficient? Or if you are going to be less radical, how well will radiotherapy compensate for that? And I don't think we've got a good answer for that, because we've never done the trials that are absolutely perfect to tell us that. But if we look at those margins, the circumferential margin, the levators, and the distal margin, if you take something like the Polish trial, where you gave 5 times 5 gray immediate surgery, so there's no downstaging, they had a circumferential resection positivity rate of 13% versus long course with enough time for things to shrink down of 4%. If you look at the distal margins are, again, there are more distal margins over 10 millimeter in the short course. And there are other papers from that show that very few patients will, after chemoradiation, have a a margin that's over 10 millimeters. And so when you look at this, you see that the short course and the and the long course chemoradiation, there is no difference in local control. So there is a sense in which it may not be perfect, but the survival is the same as well. So in some respects, radiotherapy is compensating for that positive margin. I know that Corey Marinen produced this paper which suggested radiotherapy does not compensate for a positive resection margin, and it does not compensate perfectly. But as you can see at the bottom there, even those patients with positive margins, 9% versus 16.4% local recurrence, you certainly do impact on it. You may not compensate completely, but you do impact on it. And again, in the CRO7, which is a British trial, a bit like the Dutch trial of short course preoperative radiotherapy versus selective postoperative chemoradiation, there is a reduction in the positive circumferential margin rate. There's a reduction in the local recurrence by about a third, although that's not significant. But I think if you had very large numbers of patients, it would be. So it does compensate a bit, although it's not perfect. So you're much better to concentrate on the quality of surgery. This is one of my favorite slides because it shows two things. On the left, 5%, 6%. That's the overall local recurrence rate in the CRO7 for stage 2 and stage 3. If you did good surgery, there is no difference. No difference between those if you have good surgery, because good surgery will remove all the lymph nodes. But if you don't have good surgery, there is a huge difference, 20%, 14%, 6% for your local recurrence rate, because patients are going to have lymph nodes left inside them. And even then, radiotherapy is not going to compensate entirely for that. So if you look at the randomized trials, I've highlighted on the right the patients who had preoperative treatment and the incidence of the node positivity, which are all 24 to 35%. If you look on the left, that's what I've called the control, because they're either postoperative chemoradiation in the German study or short course and then immediate surgery where you have not downstaged the patients. And what this shows is that with an interval of about 6 weeks, you are sterilizing approximately 1/3 of the lymph nodes, but only 1/3. So yes, you're compensating again, but you're not completely compensating. The problem is, when I define the radiotherapy fields and the dose, it's because you're telling me what you're going to do. So it's a bit of a chicken and egg. You tell me you're going to do a little tiny bit of surgery, I'm going to give bigger fields. If you tell me you're going to do the whole lot and a high tie, maybe I could just give treatment to the primary tumor, or just to the bit where you are worried about the margins. But is that actually what we do, or is it actually an aspiration? Is it what we should be doing, is defining our fields and doses depending on what you do? I think sometimes I do that, but I'm certainly not consistent in the way I do that. So just recently, there's been a paper from Vincenzo Valentini, which is suggesting that we have even bigger radiotherapy fields going outside the pelvis in parts. We've been somewhat surprised by that in the UK, because we've been much more concerned by the morbidity of radiotherapy. And as I said, our CTV is kind of predicated on the fact that you're going to do radical surgery and you're going to do a high tie. So I don't actually have to go right up to L4, because any nodes there, you're going to take them out anyway. So we only usually go, I don't know what the practice is in Turkey for the radiotherapists, but we only usually go up to about S2-3. So probably 20% of lymph nodes there for stage 3 will may be involved. And I'm not irradiating those. Makes the question, do I need to? But we use lower doses in the UK. We only use 45 and 25. We don't wait so long. And certainly, if you do get a complete clinical response, we don't usually give chemotherapy afterwards. And we're not on board yet with TNT, total neoadjuvant therapy, although I think that's probably coming. So we have two, as I said, two standards. Short course, 5 times 5 immediate surgery, and long course, 45 gray, 4 to 12 weeks later surgery. That's not very imaginative. It's, it's very consistent. In the UK, we use either of those, and virtually nobody uses anything different. Oscar Wilde said, consistency is the last refuge of the unimaginative. And I have to say, I think us radiation oncologists have been unimaginative. We have not tailored the doses to what we're trying to do. We have just been very consistent. That's because we're really risk averse. Compared to you surgeons, radiation oncologists are very risk averse. We stick with what we know works, and we don't like to develop that. But there have been huge technical advances in the way that we deliver radiotherapy. We can deliver radiotherapy much more safely. We can shape those volumes. My medical oncologists always say to me, oh, you're off to do the Mickey Mouse ears. That's their sort of joke for us doing our planning volumes, Mickey Mouse ears with the IMRT. We can give additional radiotherapy to the primary tumor, particularly with brachytherapy, or if you're fortunate enough to have an appropriate machine, you can give contact therapy like Jean-Pierre Girard. You can give different chemotherapy, and you can give effective systemic chemotherapy. And that alone can cause complete clinical responses. So we have a number of different developments and different ways that we could explore things in the future. So we have a lot of different treatments: radiotherapy, concurrent, cytotoxic chemotherapy alone, molecular targeted agents, and immunotherapy. Again, the last two, we have not really shown that they have much benefit in terms of the adjuvant setting yet, but I think that will come. But when you step back from it, when we give the chemoradiotherapy, for all the reasons I've said, they partly compensate, but there's still a very substantial number of patients with primary or acquired resistance, and we need innovative therapies to proceed and to get better for those patients, which are probably about a third of the patients with T3 cancers that do not respond sufficiently to the treatment and probably are not benefiting from radiotherapy and are probably only having the side effects of radiotherapy. So, strategies to enhance a pathological complete response or complete clinic. We could improve the radiotherapy, do it even better, dose escalate, boost with contact or brachytherapy. We can shorten the overall treatment time, which actually impacts on the repopulation and is more effective. They've done this in head and neck cancer by shortening the overall treatment time. We could also shorten that time and add what we call a simultaneous integrated boost. So you could actually just predominantly boost the dose to the primary tumor or a separate lymph node on the pelvic sidewall at the same time that you're giving a standard dose to the rest. You can select those cases that you think are most likely to respond, and you use what you know about things to select those patients. And you could wait longer, although it seems that there's a limit to how long you can wait in order to enhance that. You can do assessments before, during, and after your neoadjuvant treatment in order to select those patients even better. You could maybe in the future, with some of the imaging that you have, Regina, you could actually start to do things and then say, this isn't going to work, we can pull out. Or you can start and then, like some of the Italian groups are doing, you can say, this patient is responding very well, maybe we will boost this particular patient because we can see a very good response. So what we need are some validated and clinically useful biomarkers. So we've only had radiotherapy for about 100 years. So radiosensitivity markers, I don't think so. Nothing that I use on a daily basis. I don't know if you have anything. Chemosensitivity markers, nothing that I use, nothing that we do have some biologically targeted agents like EGFR inhibitors, where we can look at RAS, NRAS, and BRAF. And we have immunotherapy where there are beginning to be some markers there which can take us in that. But these are really exploratory at the moment. The best markers we have are just clinical stage. So we can see that T1 cancers, this is a pooled analysis from a lot of different units. T1 cancers, you're probably going to have about a 50% chance of achieving a complete pathological response, which goes down to about 28% if it's T2, and even further if it's T3, and even less if it's T4. What's interesting too is a recent paper looking at the subdivisions of T3, substages. So if you only have about 1 or 2 millimeters of extension through the muscularis propria, then you have a very high chance of getting a pathological complete response. And I don't know about, we have Regina here, but my radiologists tend to say, this is a T2 stroke T3A tumor. And then with some of the oncologists, they will always get radiotherapy for that because somebody has said that it's possibly T3, whereas probably it's T2. So I think that influences a lot of the trials because, you know, the trials say these are T3 cancers and there's a 30% path-CR rate in one trial and a 16% path-CR rate in that. We're not comparing like with like. So we've spent decades, I think, looking in the wrong place. We've been looking at the tumor rather than the environment around it. But we're still, the only good biomarkers are size and stage. But I think this is the future because this is a very small paper with patients having short course 5x5 gray and then waiting 8 weeks to surgery. And they looked at myeloid-derived suppressor cells and Tregs, which are your sort of immune suppression, which the cancer is responsible for. There was a significantly higher baseline for the Tregs and the MDSCs in those patients compared to healthy donors, which is quite interesting to start with. So they took blood, and they found there was a much higher baseline for those patients with the cancer. And these MDSCs went down to about 5 weeks, and perhaps even further at 8 weeks, and tended to stabilize in that period. But the Tregs, which are the sort of suppressor cells for your immune system, reached their lowest value at about 5 weeks after the beginning of short course. So if you are going to do surgery, maybe that is the ideal time to do it. So there we are, we can see these, there's a range of patients, some of them where the Tregs go right down, but then start to come up again, and some of them where the Tregs are not changed at all. So the poor responder patients started with a low basal level, and their Tregs went up. And you actually looked at the specimens again, so that when they were resected, you could see that these FOXP3, which is the effector cells and things, were different compared to the good responders. So I think there are immunological markers, and we can see that the radiotherapy does influence that. Radiotherapy causes cell death, and tumor, if it's dead, can act as a vaccine in situ. And I think that's probably why those patients in the watch and wait always have an endoluminal recurrence, and it's not usually systemic. We don't really see abscopal effects with the radiotherapy, and so probably the radiotherapy that we're doing is either suboptimal, which wouldn't surprise me, or we're just not overcoming the persisting impediments that there are in terms of the cancer's defenses for its immune system. But one of the interesting things for me is KRAS. You did, at the Memorial Sloan Kettering, you did a retrospective study showing that patients with KRAS mutant tumors rarely had a PCR. And they lack the CD8 effector cells. So there's a relationship there between KRAS and the immune system in terms of the effector cells, which are going to provide you with long-term memory cells. So the question of the future is, what is the best radiotherapy dose? Total dose, fraction size, when we should use it? I mean, short course and preoperative radiotherapy, we are taking the tumor out 5 days later after you finish the radiotherapy. That does not give you sufficient time to create memory cells. So your memory cells are in the bucket. What's the best combination of drugs? We don't know, but there are immune functions from drugs like oxaliplatin. What's the best combination? How are we going to sequence these, and how are we going to sequence this? We've got some very effective immune therapy tools in terms of the checkpoint inhibitors. How are we going to sequence these? Before, during, after? And how long are you going to go on for? But these are the questions that we're going to need to answer in the future. And we're probably going to need to design our radiotherapy differently to how we give it right now. So, the future for me is selection according to stage and size. Take those patients, I think, who are not going out to the circumferential margin, because those patients often, you have the imaging is much more difficult to confirm a complete response afterwards. We would ideally have biomarkers both for resistance and for response, and according to the immune profiling, both of the patient and at the invasive edge of the tumor. So in principle, this is the kind of thing that Gerard always gives in a very graphic way. I'm not going to do that, but surgery is effective for gross macroscopic disease. Radiotherapy more effective for subclinical disease, and chemotherapy is only effective for subclinical disease. And then there's biological targeted agents. I'm interested in robotics, and I'm interested in artificial intelligence. And we were talking about how if you ever get a robot with artificial intelligence that you're going to get to help surgery, then you're going to have to program the robot to enjoy surgery. But the question I have, which I was asking Philip yesterday, is how do you program the robot to enjoy surgery, but not to mess it up so it can keep going? But in robotics and artificial intelligence, the aspiration is for what they call the perfect 5. That you have, if you had 10, would be the artificial intelligence robot doing everything, and 1 would be the artificial robot doing virtually nothing. So you want a mixture between human and artificial intelligence to get the best result. So I've looked at the perfect 5 in terms of radiotherapy and surgery. And I think if you had good biomarkers, you could selectively use patients and base that radiotherapy sensitivity to take no need for radical surgery. You could say, this is a group of patients, you won't need radical surgery. And you could perhaps actually deliver an assessment part way, as we talked about imaging, and to select those patients better. So we can say these patients will just proceed to surgery alone, and we're not going to give radiotherapy. Or you could have patients who are less radiosensitive. Maybe you have to increase the dose of radiotherapy. Maybe you need higher doses of radiotherapy and chemotherapy. Maybe you need immune markers to do that. But these patients are inherently quite radiosensitive, but not so radiosensitive. But there are patients with less radiosensitive tumors that you might have to do a local excision or a TEM. I'm not sure that that's always going to be the best way, because I think from the immune system, that's going to take the tumor away. And it also seems to have a much worse function for patients than if you have watch and wait alone. Then there are patients who are not particularly radiosensitive, and you're probably going to need high doses of radiotherapy and radical surgery. And then finally, you've got patients who are totally radioresistant and are never going to be suitable, like some of the pancreatic cancers that are just simply radioresistant. They don't need radiotherapy. They shouldn't have radiotherapy, and you should go straight to surgery. So with that, all 3 modalities may be required to cure some patients with locally advanced cancers, but we should be in the future be able to select with biomarkers. Dose escalation may be appropriate for the smaller, earlier tumors, but more advanced, locally advanced cancers, I think, are going to need novel approaches such as the immunology. And the simple fact is, in the future, we definitely need better biomarkers. Thank you very much.